Jesus is the answer for the world today. Above him there's no other, 'cause Jesus is the way.
Today we're going to be talking about the neurodevelopmental and the neurocognitive disorders. Now, why am I starting with those, and why do we want to talk about those first? Well, first, your DSM-5 is sort of broken out, so it starts with a child going through a person's life and ending up then at the end of a person's life, but a lot of those end and early ones are sort of the same, and they have certain things we want to look at today. But the main reason for that is, when you're doing diagnosis, these take priority. In other words, if you have someone that has mental disability and they have some other problem, the mental disability is probably going to be considered the main diagnosis, or the medical problem that underlies these are the main diagnosis that you're going to use. So these take priority. And what's unique about them? Well, they start as a young person, and they start in the developmental phase as the person is growing up. Another thing that's unique about these is they're going to have a lot to do with the physical person and genes and physical problems that a person has. A lot more. Later on, a lot of things are going to be more mental issues and things like that. These are going to be more of the physical issues and the results of those physical issues. We're going to also find that these different areas that we're looking at have, some of the names have been changed. As an example, in the old DSM-4, it talked about mental retardation. That doesn't exist anymore. It isn't that the problem doesn't exist, it means that the term has been changed. And we're going to see the same thing in autism, that this is one of the main changes in DSM-5, is dealing with autism. So the first thing we're going to take on and talk about is intellectual disability, which used to be called mental retardation. And now it's a little bit different, because we're going to specify whether it's mild, whether it's moderate, whether it's severe, or whether it's profound. Or it could also be unspecified if you didn't specify what it was. And this is about 1% of the people, about 0.6% it's severe. Now, what do we do to think about intellectual disability? Well, we think of an IQ test, right? Well, that's only part of it, but actually they've changed it quite a bit, that intellectual disability really has to do with functioning more than it has with IQ. You could have a person with a lower IQ that functions better, and the question is, how well can they function in society? That's what we're talking about here. So here are the criteria. The onset in the developmental period with both intellectual and adaptive functioning deficits. Do you notice that? You have to have both of those for a diagnosis of intellectual disability. And they have to meet all three of the following. Deficits in the intellectual functioning, such as reasoning, problem solving, planning, abstract thinking, academic learning, and learning from experience confirmed by a clinical assessment and testing. They also have to have deficits in adaptive functioning that result in failure to meet developmental and social standards from personal independence and social responsibility. And now you're going to also say from there, it's going to be without ongoing support, the adaptive deficit limited functionings of one or more activities of daily life, such as communication, social participation, and independent living. If they have to have support. So that if they don't have to have support, again, this doesn't apply here. And it has to be across multiple environments, such as home, school, work, or community. And the onset has to be during the developmental period. Now, what's interesting about all of these from a coding standpoint is that all of this, the whole thing, and they're taking all these possibilities together, is coded in ICD-9 as 319. And that's all. So it's all the same. It's all lumped together. But when we get to ICD-10, then there's going to be F70, which is mild, F71, which is moderate, F72, which is severe, and F73, which is profound. And basically, people are going to be in the range of about 65 to 75 on the IQ test. So what do those look like? I've got a client sitting in front of me, And this client, how am I going to determine what's mild and so on? And it defines it all for you. Mild is a concrete approach to problems, immature social interactions, need for support in employment and healthcare decisions. Moderate is ongoing assistance required. Assistance in life decisions takes longer to learn. Severe, little understanding of written language or numbers, speech in single words or phrases, here and now, support for all activities, cannot make responsible decisions. Some have maladaptive behavior and self-injury. And profound. Many may use objects in a goal-directed fashion, may be able to match and sort, little understanding of symbolic communication, gestures, and basically little social concept or functioning or anything like that. Okay, so you see the picture. I think we all know that's what we used to call mental retardation. We have a picture of what that sort of is. Co-occurring. You have all sorts of things, but what's lumped into this whole thing? Because what they've done is they've taken all these things that you know about and they've lumped it all together into one thing here called intellectual disability. Because this includes Down syndrome, this includes Fragile X syndrome, PKU, Tay-Sachs disease, fatal alcohol syndrome, birth-related issues. So do you see that they've taken all of these whole areas and they've all put them just in this one? Now they have another one and it's called global developmental delay. And what that is, if the kid's under 5 years old and they're so dysfunctional, you can't tell how dysfunctional they are. You just lump them into global delay, and then later on you give them a diagnosis. You can also have unspecified intellectual disability. They're over age 5, but they're so dysfunctional you can't make a diagnosis. You can't really figure out what the problems are that are going on. So do you see the picture? And of course, remember we have specifiers. So do you see what you would do? The overall diagnosis would be intellectual disability, but then the next line would say with Down syndrome, with these other things. So you would have specifiers that you would add to it to clarify what's going on. Because remember that in DSM-5 we don't have those axes like we had in DSM-4 to break things out. You put it all in the one diagnosis. So that's the first thing in developmental issues that we're talking about. The next big grouping, because that's what they've done, they've grouped everything together, is called communication disorders. And under communication disorders, we're going to have language disorder, speech sound disorder, childhood onset fluency disorder, social communication disorder. So we're going to lump those all together now in one category. But there will be individual codes to break these things out. So what is language disorder? Persistent difficulty in the acquisition and use of language across the spoken, written, and sign language due to deficits in comprehension or production that include limited vocabulary, sentence structure, and discourse. They have to be below expectation. Onset has to be in the developmental period, and it can have to do with hearing or sensory impairment or motor function, or medical or neurological conditions. Do you see what they're doing? They're saying, no, you can't be for these other things that are causing that. If so, you're going to give them the other diagnosis for those other things that we'll get to in a little bit. But if it's just separate, they're okay except for this particular thing, then you give them this diagnosis. Speech sound disorder. Persistent difficulty with speech sound production that interferes with intelligibility and prevents verbal communication and message. Disturbs effective communication, social, academic, occupation. Onset and developmental period. It's not congenital or acquired conditions such as cerebral palsy, cleft palate, deafness, hearing loss, traumatic brain injury, or other things. So you only give this diagnosis if it just fits this narrow thing. It can't be caused by other things. Childhood fluency disorder, or stuttering that starts in childhood. We'll have stuttering later on when you're an adult, but this starts as a child. Disturbance of normal fluency and time pattern of speech for the age, including at least one. sounder syllabus repetitions, sound prolongations or consonants as well as vowels, broken sounds, audible or silent blocking. It means they go along and they just sort of stop. Or they might make some sound during that particular thing. Excess tension and monosyllable whole word repetition. Like that. They cause anxiety about speaking, limited effective communication, social participation. I actually had an adult client that had a terrible stuttering problem, and you couldn't, if you get him calmed down enough, you can sort of figure out what he's saying, but otherwise the stuttering was that bad. Early development onset. You don't give them childhood onset, you would give them an adult onset if it started when they were an adult. Not speech, motor, or sensory deficit, stroke, tumor, or trauma, or other medical condition. Good news is 66 to 85% recover from this particular thing. And then we have social pragmatic communication disorder. Persistent difficulties using communication for social purposes as greetings and sharing information in a manner appropriate for the social context. Impaired ability to change communication to match the context. In other words, they're sort of weird. They don't come across right. You know there's something funny going on here. That's what we're talking about here. Difficulty following the rules of conversation and storytelling, such as taking turns, rephrasing or using verbal or nonverbal signals. Difficulty understanding what is not explicitly stated. We might say this is sort of social skills type of thing. Well, this is the category that particular thing falls under. And then we have specific communication disorders, specified and unspecified. What that all means is, let's say somebody doesn't fit the rules that we just laid down for a diagnosis. Well, then you can say they fit this diagnosis, except specifically they don't fit this criteria. And then the last one, unspecified, says they don't fit, but it's still a communication disorder. I can't really tell you what they don't really fit, so we're just not going to specify for right now. Later on we might re-diagnose. Now the one that's caused the most heartache is the next one, autism spectrum disorder. Now why is it causing a lot of heartache? Well, because we used to have things like Asperger's and different things like that, which is sort of low-level autism. Well, you don't have that anymore. Good news is you still have specifiers, so you can help the situation that way. But generally, they've taken all of these issues and lumped them together in what is now called autism spectrum disorder. Previously, it was called pervasive development disorders. It's about 1%. The symptoms appear before age 3. 2/3 of them cannot lead independent lives in adulthood. They react badly to change. They tend to stimulate themselves and sometimes injurious behavior. So what's the criteria? Persistent deficits in social communication and social interaction across multiple contexts. That means they're at work, they're at home, they're at school, and so on and so forth. Social emotional reciprocity, meaning that you say something, they don't say anything back. Nonverbal communications, developing, maintaining, and understanding relationships. So that's the first one. Second one, restricted repetitive patterns of behavior, interests, or activities as manifested by 2 of the following. Stereotyped or repetitive motor movements, moving objects, or speech like lining up toys, flipping objects, and so on. Insistence on the sameness, inflexible adherence to routines and rituals, highly restricted fixated interests, hyper or hypoactivity to sensor input, meaning that they're really sensitive or they're not very sensitive. They either pick up a lot or they don't pick up a lot. Early development, again, clinically significant impairment, includes Asperger's disorder, infantile childhood, Canaan's, high functioning, atypical autism, persuasive development disorder not otherwise specified, and childhood disintegration disorder. So we have all of those things that we used to talk about as specific things, and they're now saying they're really the same thing, just different parts of that same thing. So it's sort of all grouped together. And of course, if you already had a diagnosis of one of these specific ones, do you want to have your diagnosis all changed and everything? Well, that's what's going on in the whole field there. Specifiers, with or without accompanied intellectual impairment, language impairment, known medical, genetic, or environmental factors, known medical condition, or catatonia. Catatonia is more where they just freeze, or they just don't move, or they have interesting movements and things like that. Severe level requires support. They have different levels again, whether it is the mild, moderate, and so on. Early features are impaired joint attention, such as lack of pointing, showing or bringing objects to share interest with, or failure to follow someone's pointing or gaze. So if you're looking at a little baby, that's the list I just gave you of the things that you might pick up that this kid might have autism. Let me read that to you again. Okay? Lack of pointing, showing or bringing objects to share interest with others, if they don't do that, or failure to follow another one's point or gaze. Those could all be signs of the beginning of autism. What causes it? What's the etiology? Inability to comprehend sounds, stimulus over-selectivity, genetic factor, possible cause of prenatal difficulties, maybe multiple biological causes, parent interaction, they don't really know. So this is one of these things, we're going to get quite a bit of those today. They really don't have very good ideas of what's causing this. They just know that it's a major, major problem of some sort. So treatment. Help them to adapt to their environment by limiting the environment. There are some drugs that help, but primarily just deal with the behavior modeling and shaping. Stopping the self-injurious behavior. Try to teach them some communication skills. Only about 50% speak. My wife sometimes, she's a substitute school teacher, and she gets called to work with a special ed and so on, and they have quite a few autistic kids. And what they're doing, they actually sometimes have like one para for each kid almost, because they have to work with them that much, and you're working at such a rudimentary area, and we're going to see that. See, the different areas that they probably will work on is behavior and communication therapies, new skills, social skills, communication, education therapies. If they can have the right thing. I know there were some cases where they had like computers set up where the kid to communicate could just point at pictures. And so there are different ways that they try to help these kids get more functioning. But generally, without a miracle, they're pretty much locked into this, but you can help their functioning over a period of time. Family therapies to help the families get along with this better. Medications, there's no medication that can improve the core signs of autism, but they can control some of the symptoms. Managing medical conditions. There are many times other problems that are associated with this. That's what makes it so complicated, is that they can treat some of those other conditions to try and help out the situation. The next one we're going to talk about, you might not think belongs here. Attention deficit hyperactivity disorder. But it's also considered a neurodevelopmental disorder, because now they have found that there's a lot more physical involved in this, in the brain functioning and so on, as they've been able to do PET scans and be able to see what the brain is doing, and that's why it's now been moved over here instead of maybe an anxiety disorder or something else like that, that is considered to be more of a physical problem than a psychological one. We're talking 5% of school children, 2.5% of adults. The mind sort of just gets out of focus. And they've now changed it so we only have 3 categories that we'll be looking at. We have the inattentive type. We have the impulsive hyperactivity type. Those are combined together in a mixed type. But there's quite a bit more in the field there that I'll mention to you here in a little bit. What are the criteria? They either have the inattentive or the hypoactivity, impulsivity for 6 months that is maladaptive, immature, as showing the following occur. So if you're doing a diagnosis on this, you have to be licensed as a clinical counselor of some sort to do diagnosis officially, but you can do assessments. Say, yes, I agree with this, yes, I understand that kind of thing. And you need to have 6 of the following. Fails to pay close attention to details and makes careless errors in schoolwork, work, or other activities. Has trouble keeping attention on tasks. Doesn't appear to listen when being told something. Neither follows through on instructions nor completes chores, homework, or jobs. Has trouble organizing activities or tasks. Dislikes and avoids tasks that involve sustained mental effort like homework or schoolwork. Loses materials needed for activities. Easily distracted by external stimuli. Is forgetful. So that's the inattentive type. You have to have 6 of those for a diagnosis of inattentive type. Hyperactivity, impulsivity, at least 6 of these. Squirms in seat and fidgets. Inappropriately leaves seat. Inappropriate leaves seat and runs and climbs. Has trouble quietly playing and engaging in leisure activities. Appears driven or on the go, talks excessively. That's the hyperactivity. Impulsivity, answers questions before they have been completed, has trouble waiting their turn, interprets, interrupts, or intrudes on others. Some of these symptoms began before age 12. It used to be age 7 in DSM-4. It's now changed to age 12. It has to be present in at least 2 types of situations. It can't just be at home. It has to be home and school, or it has to be school and work if they had work, or something like that. The disorder impairs school, social, or occupation. Not solely associated with development, psychotic, mood, anxiety, or dissociative or personality disorder. And they break these into those separate different things. So what do they think the problem is? It's in the prefrontal cortex or the temporal lobes that provide concentration and memory. So those are the areas that seem to be affected sort of in the brain. Now there's a doctor named Amen that's done a lot of research in this particular area. He's got a book out called Treating ADD, and he's done it with PET scans. So they can actually watch a person as they're thinking, whatever. Like they'll take a person without ADHD and they put them in the machine and they have them concentrate. And what do you think happens? Their brain lights up. If you take somebody that has attentive type of ADHD and you put them in and you ask them to concentrate, guess what happens? The brain shuts off. See, that's why we're going to see in the treatment here that they use stimulants, because stimulants can help the brain keep awake and doesn't shut off, and then the person can function better. One of the interesting things here, if you want to know if a person really has it experientially, if you give them a stimulant and they don't have it, what's going to happen? They're going to go through the roof. They're going to be hyper. They're going to be running around doing all sorts of things. But if you give somebody with ADHD a stimulant, they're going to just calm down. So you can see why that's one of the answers here. I'll just mention some of the other types that they found that are not in DSM-5. One is an over-focus type. It's excessive activity in the anterior cingulated gyrus. That's the brain's sort of gear shift. This person worries excessively, is oppositional and argumentative, locked into negative thoughts and compulsive behaviors like OCD, gets locked into subjects, can't see options or actions, needs to have things done in a certain way. That doesn't really sound like ADHD, does it? So we were saying that there's some other types that they found that are the really confrontive and negative type of things, and they still show as brain dysfunction in this same category. Temporal lobe. And the temporal lobe is responsible for mood stability, learning, temper control, has decreased activity. This type of ADHD has quick temper and rages, misinterprets comments as negative, recedes, irritable, explosive, and tired cycle, periods of spaciness and confusion, panic and fear without reason, imagines visual changes, history of head injury or family history of violence, dark suicidal or homicidal thoughts, forgetfulness and memory problems. Can you see you can have a huge range here of different things that can be going on? And I've had some interesting ADHD clients that one of them had actually 3 or 4 of these different types. And parents were really having a lot of fun trying to handle this kid. She's like a 12-year-old girl. And she was doing about everything you can possibly imagine. But at least if you realize that it's not them being this oppositional and so on, you can at least back off a little bit and say, hey, there's something not functioning here exactly right. The limbic type. Depression, decreased prefrontal cortex activity, left side, but improves when they concentrate. Moodiness, negativity, low energy, social isolation, hopelessness and helplessness, low interest, sleep changes. So this one looks totally different than the other ones. This person's just a kid that seems like they've dropped out. Like nothing's really going on here. And then the most interesting one they called Ring of Fire. Because when this one they put in the PET scan, their whole brain lights up. Increased brain activity overall. And in this case, what's interesting is if you use Ritalin or Prozac, which is the normal drugs that they use for this, it makes them worse. Angry and aggressive, sensitive to noise, light, clothing, and touch, cyclical mood changes, insists on their own way, excessive talkativeness, impulsivity and unpredictable behavior, grandiose thinking, thoughts race. All I'm suggesting is there's so much here to sort out in the whole area. And so it's good to have some tests and so on to use to sort of checklist to try to figure out if you're dealing with this particular area. And we said 5% of kids fit into this particular area and have these kind of things. 50% of these kids also have learning or communication problems. 80% misbehave and develop contact, substance use, and antisocial personality disorders. 50% are oppositional defiant. 1/3 continue into adulthood. The other third sort of get well pretty much on their own. What's the problem? There are a lot of theories. Minimum brain damage can do it, stress, multiple interaction, low birth weight, child abuse, neglect, smoking and infections, alcohol exposure, toxins, genetics. In other words, we don't know. In other words, there's a lot of questions. We just know that there's a lot of people that struggle with this particular thing. And of course, we have specified and unspecified attention deficit disorders. From that ADD book he mentioned some, he calls them ADD games. Listen to these and see what you think. Let's have a problem. I bet I can make you hit me or yell. My thoughts are more terrible than yours. It's your fault. You can't make me do it. I'll say the opposite of what you say. Say the first thing that comes out of my mind. Let's call it even. You criticize and I criticize you. Fighting is foreplay leading to love. When you're dealing with somebody that's really struggling with ADHD, those are the kind of reactions that you get. Treatment. There are stimulant medications, non-stimulant medications. The main ones you're probably going to have heard of are Ritalin and Adderall and Vyvanse. But there are also a bunch of non-stimulant ones, pretty much the antidepressants and things like that that have been used for these particular things. Another one that sometimes people believe in, but it's not really backed up much by research, is the Feingold diet to eliminate flavorings and coloring. But there's not too much research support for that. But some people try that. They think it's the coloring that's triggering a lot of this kind of stuff. How about in counseling? Behavior therapy, trying to sort things out. What's one of the first things we try to do? Let's get some family rules. Let's get some blacks and whites. Let them make some choices and learn by those kind of things. Psychotherapy, so they can talk about the issues. Parenting skills training. Family therapy, see if we can stabilize the family. And social skills training. And the best thing is a team approach. We got the doctor, we got the counselor, we've got the person giving the medication, and you all work it together because they react a lot. One of the things about the medications is if we're using a stimulant and we have too little, what's going to happen? Not much. If we have too much, what's going to happen? They're going to go through the roof. So unless you get this balance someplace in the middle, you're going to constantly have problems. Either they're not going to be functioning or they're going to be going through the roof. And so you go around and around and around in the medication if you're counseling these people and trying to get these things together. The next thing is specific learning disorder. They've taken all the learning disorders and put them all together as to one particular area. What's the criteria? Difficulty learning and using academic skills with one of the following over 6 months. Inaccurate, slow, or ineffective word reading. Difficulty understanding the meaning of what is read. Difficulty spelling. Difficulty with written expression. Difficulty with numbers. And difficulty with mathematical reasoning. What did those used to be called? Mathematics disorder. There were different names specifically, and now they're all lumped together with specifiers again. The skill must be substantially below expected level for the age. It has to be begun at school age, and it's not intellectual disability, vision, hearing, or other medical factors. How do we break it out? Specifiers again. We have specifiers with impairment of reading disorder. That would be dyslexia and so on. Accuracy, fluency, and comprehension. Impairment of written expression. Impairment of mathematics. And again, moderate, mild, moderate, or severe. So do you see how the whole thing's changed? You start getting the idea? They've taken all these areas in which they tried to make them into separate areas because they realized they influenced each other. They make them into big areas, and then they add specifiers at the end. So you still have basically the same thing. The person that had mathematics disorder is going to have what? Specific learning disorder with problems with numbers, or with problems with mathematical learning, and so on. Learning disabilities are highly inheritable in families. 4 to 10 times the number of people in the same family will have the same learning disabilities. 2 to 3 times more common with males. Next area is motor disorders. This means that the way they move and the way they function. And we're going to break out a whole bunch of those again. Developmental coordination disorders. Stereotypical movement disorders. Tourette's disorder. Persistent chronic tic disorder. And provisional tic disorder. Now, what in the world is all that? Let's start at the top. Developmental coordination disorder. Acquisition and execution of coordinated motor skills is substantially below the age, such as clumsiness, slowness in accuracy. Interferes with daily living. Onset development not explained by intellectual disability, vision, neurological conditions such as cerebral palsy, muscular dystrophy, or degenerative disorder. Stereotypical movement disorder. Repetitive, seemingly driven and apparently purposeless motor activity, such as handshaking, waving body, rocking, head banging, biting, and hitting themselves. Interferes again with the different activity. Now, Tourette's is interesting because the main thing of Tourette's of how it is different. We've always seen it as this totally different thing. Okay? They have both multiple motor and tic disorders. So you can have, sometimes person can just move. You know, those are called tic disorders type things. And they have to have at least one motor and one vocal. I've had some clients with Tourette's before. And as they're going along and talking, it just this jerks in their talking as they're going along type of thing. And then also just be a jerk of their head. But the idea is you can have that. If you don't have both, for Tourette's you have to have both, okay? You have to have at least one motor and at least one vocal tic. If not, you can have persistent or chronic motor or tic disorder, and then you have to specify if it's a motor disorder or if it is a verbal tic disorder that's going on there. And then you can have provisional tic disorder. It's less than 1 year that the person has a tic, but they have to have it for over 1 year to give them a tic disorder. So that is the list of developmental disorders. But we want to deal with one more thing today, and that is what are called neurocognitive disorders. And the way we used to know those names, because all the names have changed, you have to just understand what we're dealing with here, is delirium, dementia, and amnesia. Again, all of those are seen to be one category now, so they've lumped them sort of all together, but we do have some specific breakouts in those particular things. So when does a person have delirium? Here's the criteria. Disturbance in attention, reduced ability to direct, focus, sustain, or shift attention, develops over a short period and fluctuates during the day, disturbance in cognitive such as memory, disorientation, language, and perception, not otherwise explained by other neurocognitive disorders. Evidence, it is a direct psychological result of a substance or medical condition. What would be a delirium thing that we always see in the movies? Someone has a high fever. They have malaria or something like that. But do you see what we're saying? If we're talking delirium, it starts as an onset. There's some sickness or something medical going on with the person, and that's why they're not functioning mentally. They're sort of out of it. They don't know where they are. They're disoriented. And that's what's called delirium, okay? But the biggest one that we probably have is what is now called major neurocognitive disorder. It's when we have things like Alzheimer's, frontal lobe disorder with Lewy bodies. That's a very interesting one. We'll go into those in a minute here. Criteria: significant cognitive decline from a previous level of performance in one or more cognitive domains, which are attention, complex attention, executive functioning, learning and memory, language, perceptual, motor, or social cognition, based on, what's the criteria? Concern of an individual, informant, or clinician, and testing. The thing that's interesting about this is we can figure out why these things are happening. In a lot of other of these categories, we can't do that. We don't know. You know, for ADHD right now, we don't know physically what exactly has gone wrong. We can just see the brain isn't functioning right. But mostly when we're talking about dementia, you know what the reasons are that are behind the dementia, what's going on here in the person's brain, and so on and so forth. The defects interfere with independent living of everyday activities. It's not exclusively in the context of delirium, and it's not explained better by a mental disorder such as depression or schizophrenia. So these are the medical causes. And if you're doing this, the way you code it, you actually code the medical cause first. And then you would code the major neurological disorder next. Because what's the cause? The one is the result of the other one. So that's the reason you're going to do it that way. So Alzheimer's disease. We all have sort of heard about that. And we understand the struggle that a person has, and it gets worse and worse and worse. Frontal temporal disorder. Neurocognitive disorder with Lewy bodies. Lewy bodies are the second most prominent protein, is based on protein deposits. And here's an interesting thing. They can cause hallucinations. The people will see people, animals, or deceased loved ones. So we're talking about the spiritual here. When we end this up, we're going to tie that all together. But can you see how we might have spirits involved here again? Because the person's brain functioning has gone down. They can't really defend their brain. Where do you think they're seeing deceased loved ones? And they're seeing people, and they're seeing animals, and they're seeing stuff. Those are called hallucinations. So I'm saying that you can have some psychosis type of things that are involved in this. Vascular and neurocognitive disorder. Due to trauma and brain disorder. HIV infection can cause this. Prion disease, Parkinson's disease, Huntington's disease, then other medical condition, and multiple etiologies. So there are a lot of reasons. Again, we've put them all together into one overall category. Now, mild neurocognitive disorder. Evidence of a mild decline from a previous level of performance, concern of individuals in testing, does not interfere with the capacity for independent living. This is the person, you know, this is your mom or whatever, and she's forgetting things and she doesn't remember to turn the stove off, or, you know, some things like that. That would be still in the mild category, just so it wasn't dangerous. Prevalence steeply increases with age at around after 60 years old. 1 to 2% have the problem around 65, and 30% have the problem by age 85. What can we do to treat this? How can we help in these particular areas? The first type of medication that they have, ever hear of Aricept? Okay, there's a whole bunch of these, like Aricept, Exelron, Razidine, choline ester ACE inhibitors. Then we have Menantine. This works regularly on glutamate. So you have different things. Basically, it's a problem in the brain, and they have different things that can slow this down, but they can't really stop it. Again, there is no cure at this particular point. What's another thing we do from a counseling point of view? Occupational therapy, helping them function as much as possible. Modifying the environment, you know, putting in railings, all the kind of things that you can do to help that way. Modifying your responses. Learn to be cool, calm, and collected, and not to blow your top, and not to do all sorts of things which just trigger them and make things. And modifying tasks. Break the task into smaller things. For my mom particularly, it was making lists, because she had lists all over the house and every switch what it did, and so on and so forth. Even in the car, everything in the car had a little line underneath it saying, you know, this is the lights, this is the key, this is and so on and so forth. And so we would do in more complex tasks is we would give her a checklist. Okay, to turn on your VCR, or turn on your DVD player, you know, turn this on, then push this button, then do this. But as she progressed, even that wasn't enough. And so it's going to get worse and worse at some particular point, and you have to deal with all those kind of things. But now let's tie this all together, okay? And the way we tie it together all the time is with SPEC. Remember SPEC? We got to go through these things and decide how much of this is spiritual, how much of this is physical, how much of this is the person's experiences, and how much of this is the person's choices. And today it's going to be fairly easy. Okay? So what are we going to say? On all of these, what is the primary cause? Physical, right? So if you cast out the demons, is it going to necessarily do a lot of good? But there could be, in some of these cases, when you have psychosis and hallucinations and stuff like that, and talking to the dead and seeing things and those kind of things, which can be associated with this stuff, even with autism. There can be spiritual factors that can be causing and making these things worse, so you don't want to say, no, that's not part of it. And there can be experiential. When the kid is, you know, let's think about ADHD right now. The picture I have of ADHD is a bunch of kids in a race, and one of the kid has a 100-pound backpack on. How are they going to feel? This isn't fair. I can't do it. I can't measure up. I have to try so hard to concentrate. And see, those are experiences that they're getting now, so that's going to make it worse, and that's why you have so much opposition and other stuff going on in ADHD. Is because everything they try, it just seems life is so much harder, and then the people that are pushing them, how do they like their parents saying, you got to do this, or why don't you do your homework, why don't you do this, and so on and so forth. But also, are there choices involved? See, even with an autistic child, there are choices involved in all of that. And so for each individual person that you're counseling, no matter which one of these areas that we're talking about, you're going to have to sort out with this particular individual. Do they have any spiritual things affecting this? How bad is the physical situation? How about their experiences? How much that affecting them? And how about their choices? So each one of those we sort of break out. Probably the autism is probably the strongest one here, intellectual disability. We have all of those kind of things, but even the delirium. You know, do you think it's possible if someone's in delirium that spirits could get a hold of that and do something? Or take advantage of that? Or the person could make bad choices when they're in the middle of delirium, when they don't know what's going on. So your job as a counselor in these particular things is to sort them out the best you can and get them the best kind of help that you can. Many times, of course, realize with God, anything's possible. So we definitely want to pray for their healing to start with. But we then need to go and get them whatever help we can get them, maybe in the way of training, maybe in the way of social training. All of those kind of things all fit into this particular group. And this group's a little bit different than other groups we're going to be looking at just because there's such a strong genetic and physical component to all the stuff that we've discussed today. But anything is possible with God, right? Let's pray. Lord God, we thank you that even these very difficult things, that you can help us understand them, put them together, and help people get the things that they need to function as well as they can. And we believe miracles are possible, and we believe that you can heal all of this. And we ask your direction and your help, and we give you all the glory in Jesus' name. Amen.
Jesus is the answer for the world today. Above him there's no other, 'cause Jesus is the way.